Right, Sam, do you want to go first?
Sure. Again, I don't have a whole lot of updates since last time. I submitted the manuscript. Me and Eugene wrote the variance manuscript, so I'll follow up on that over the course of the next few weeks. And then in terms of patient data, today I was going to send out the emails to Alex, Dr. Abazid,
Yeah,
and then just to see if they have any ideas of other patient lists that might be available.
right.
And then for Dr. Barat, do you want to give him a little bit more time before I reach out? Or do you guys want to reach out just because you guys were talking with him before?
Yeah. Let me email him today because I know
Okay.
he'll be out. I don't know, but yeah,
Okay,
I'll email him today.
perfect. So I'll send those emails once we're off of here. Otherwise, I just have been writing like a draft introduction for the study. I can share it, or otherwise I can just show it to you later. That's pretty much all I have for now.
Okay, I just good. Hopefully we'll figure out something soon and you'll start data collection.
Yeah,
Um, well, I guess the variables that you'll be collecting, you showed me that or?
yeah,
Yeah,
yeah. I showed you, and then we went through, and you kind of gave suggestions. So that's pretty much everything's ready to go from the like chart review perspective.
yeah. Oh, have you done any literature reading on like what others have like done so far?
Yeah. So I looked into like mostly the Lunit papers because they seem to be the ones doing the majority of the
Yeah.
like AI pathomics, at least in terms of tumor infiltrating lymphocytes.
Mhm.
And then I presented that one study, I think last week or 2 weeks ago, just
Mhm.
briefly, about how they validated it in the non-small cell lung cancer cohort.
Right.
So they're, I guess, sort of the leaders in
Yeah.
terms of the AI side of this.
So I just sent you a paper they wrote recently. It's not published yet, but you can read it.
Okay.
They looked at Stanford and our own as well as some Korean hospitals, and they looked at pan tumor and showed that this is far better than PD-L1 or TMB, you know, regardless of histology. If they got immunotherapy, the TIL is what correlates best.
Yeah.
So
Okay.
yeah, really nice paper. Just, you don't have to cite it, but just kind of see what kind of analysis they've done and
Yeah.
and then you can look at their methods and kind of learn from, what they've actually done. But yeah, spend time. I mean, they can't be the only company doing this or only lab. So there's gonna be
Yeah.
a similar approach. And some people, like I said, some papers are in lung, some papers are in melanoma or breast. So kind of yeah, on next lab meeting, why don't you present like in each tumor types, the TIL or similar approach. And some companies might not use the actual like H&E, but they could have similar results by just doing like RNA, like named signature. And so I guess don't look at too much, but focus on neoadjuvant setting. Like there shouldn't be many papers. Like if neoadjuvant setting, if someone says like, oh, inflamed signature, then their response to neoadjuvant chemoimmuno, or immunotherapy resulted in a really good like PCR or something. I think we should at least know about it. And I'm thinking like for the discussion of this paper, it's better to put some sort of table describing like where we are. So yeah, maybe work on that first before we get the data. Yeah.
Okay.
So it's the immune subtype, or the immune inflamed subtype, and sometimes defined by kill, sometimes defined by RNA. I don't, DNA shouldn't be able to define it. Protein is possible. Like you can stain for T cell markers. So yeah, that's feasible. But nothing from blood, or it's strictly like inflammation marker from the tissue,
mhm.
and how that affected outcome of neoadjuvant therapy in different histology. So that's the question we're asking. And I think understanding that is really important. Number one, to see if we can replicate any of their findings. And number two, what is unique about our paper then? Like where's the niche?
Okay.
Yeah.
Okay, I can work on that. I start radiology today, so I'm not sure what my schedule will look like, but this might be my only lab meeting, at least for this month. But I'll let you know. I have my orientation at 10, so
Oh, okay. Yeah. And then we're gonna be doing it like 8 till like usually like 11-ish.
okay.
So if you can like manage to come in like 10 minutes for like during break of anything, like wherever you are, and do
Yeah.
this brief update, that should work too.
Okay.
But then if you want me to kind of go through something, but you don't have time to be here, send it to Liam, and he'll kind of put it on the screen, and I'll give comments, and you can watch that video later. That's
Okay,
how
perfect.
we'll work together. Yeah,
Yeah. Okay, that sounds good.
that's it.
Yeah, and then did you have a chance to look at that form just for like research credit?
Oh, you didn't. I filled it out and told my assistant to send it out. I think
Oh,
I
okay. She might
yeah
have just sent it in then. That's fine.
yeah maybe
Okay.
Leslie,
Yeah.
just
Okay.
just confirm with her that she sent. I thought she sent it, so
Perfect. I'll just double check.
yeah.
Thank you so much.
No problem. All right, let's go to Richard.
Yeah. Hi. So I did a bit of writing this past week for the Nivo IPI trial. Let me show it. Can you see my screen?
Yeah.
Okay. So I wrote the methods and the results section, and then like put together a bunch of like figures too that I can go over after. But for now, I tried to like mimic the structure of the other paper you wrote and a couple of other papers I found online, but I just want to make sure that like what I wrote was correct, because like I don't really know like what I was writing at some points, but it seemed to make sense. So this is what I have for now.
Yeah, I think it's pretty straightforward.
Okay. There was one question I had.
Uh-huh.
So I got the like study trial information sent to me by Liam, and I was looking through it for like the design of the trial,
Yeah.
like like stage 1, stage 2, how many
Uh-huh.
patients
Uh-huh.
like
Yeah.
remained. Some papers include a pre-specified ORR that they like needed to satisfy like either like a null or alternative hypothesis.
Yeah. So Liam, this is also important for your papers. Yes, it should be described, and it should be part of the protocol. It's in the protocol, actual protocol. So
Okay.
I
Um,
don't think that's written in other Dart papers. If you, so get the actual Dart protocol and other previous, like a CCR papers from Liam, and it should be written there, because I think the response rate was,
Is this the same? So was the null hypothesis the same as the Dart paper for this?
oh, this is not the Dart. Very similar to Dart, but I guess. So I guess so we should get the protocol for this.
Yeah, Richard didn't remind me. I think we got you the protocol, right?
yeah, I have the protocol. I just couldn't find the like the exact like ORR in the protocol.
So it wasn't there?
Not that I could see. It might be there and I couldn't find it, but I tried looking for it and I
Oh,
couldn't find it.
really?
Uh,
Oh, that's really interesting. Usually there's no hypothesis.
Yeah, typically, like if you search null hypothesis or alternative hypothesis, it should give you like the preset cutoff
Yeah.
percentages. For Dart, it's 30%.
Mm-hmm. It was like 5 and 30. I can check again, and then if I can't find it, I'll like reach
Yeah,
out.
if you can't find it, it's okay, then don't write it. That's not in the protocol. So
Okay.
maybe it was just omitted by mistake. I don't know. It was just long time ago, like this was written like 6 years ago or something.
Yeah, a long time ago.
Yeah. Yeah, so if you find it, write it. If you don't find it, I don't think we have to write it. If the reviewer says like, why don't you have it? Like, in the protocol, we did not specify a
Yeah.
hypothesis. It's a
Yeah.
descriptive study or whatever, it's, yeah.
Oh, yeah.
But good question, yeah.
Okay. Moving on. So I wrote like the patient characteristics. We're still waiting for like the updated table from the like stats team about like histology, and I think they're trying to figure out the OS and PFS using IR RECIST criteria
Uh-huh.
as well. But besides that, I wrote up like the outcomes. It's pretty similar to what I wrote down in the abstract. And then I have some questions about toxicities and when I was writing it out. So, oh yeah, a lot of papers wrote down like the total number of patients with any adverse events. They didn't calculate that for the stats team. Should I ask about it, or like, do we need that?
You mean, what your question is, what was your question? Total
So
number?
like and for what the stats team did, like it was like 54% of patients had fatigue, 46% had lymphocytopenia, but they
Yeah.
didn't say like how many patients had any adverse event at all. Like 80% had one, at least one.
Oh, yeah. I think it's good to have it. I think it's
Okay. And then other papers didn't talk about serious adverse events. Should I separate that from like normal adverse events?
like grade 1, 2 versus 3, 4.
No,
Yes.
they're separate. They're like also grade 1 through 5, but serious. Like they're separated from normal.
Oh, yeah. So it's a grade 1 to 4, and then you have grade 3, 4 as a serious, right?
Let me see if I
How did
have
they
it.
separate it?
Here. Uh, so it's like these were like serious adverse events. And then these are separate from like adverse events.
Oh. Okay, go back. Oh, no, I'm saying the serious, the serious. So all this is still all grade.
Mhm.
Oh. Interesting, anorexia is here. Huh.
Yeah, there are only 5 in total.
Yeah, I think this was a practice, but like, it's more like adverse of our own interest and kind of look at these more closely, but they're already in like the whole, total, the whole AE list. So I don't think you have to mention this as a separate category.
Okay.
But look at it, grade 1. So all grade percentage as well, and then so grade 3, 4 combined and call it serious, or grade serious, and then just call all like grade 3 and 4 adverse events can be reported separately. That's usually what people do.
So you're saying like I'll just like describe like the most common. Is that like enough? Like just like this one is the most common grade 3, 4 adverse event.
Yeah, so I want you so among all so you all stages, what among all are you talking about all AEs?
Oh
All,
yeah, all
not,
um
yeah, all grade adverse events. Yeah.
Mhm.
So the most common adverse events include, yeah. So do the same thing for, among all serious grade, among all grade 3, 4 adverse events. Among, what are the common ones? Maybe top 3 and their percentage and number.
Mhm.
Yeah, to be more descriptive. Yeah.
Okay,
Yeah.
sounds good.
Want to know what are, because that's what affects our practice. Like these are the causes of admission for
Mhm.
patients. Yeah.
Yeah, okay. And then other papers also talked about immune related events. So they like separated out the ones that are immune related. Should I do that too, or is
Yeah,
that necessary?
let's do that.
Okay.
And those are immune related are if you look at the paper, so for every clinical trial, investigators are obliged to sort of check Nivo related, IP related, right? So if any one of those are checked, then you're going to call that AE immune related.
Oh, the only ones I did include were Nivo or IPI related.
Yeah.
So,
I mean, no, I'm saying for the immune related category, immune related AE, use the one, yeah, in which those 2 checkboxes, either one, Nivo or IP, are checked.
oh, okay. I think these are all immune related. Like I only use Nivo or IPI related. Okay, I'll change that.
Oh,
Uh,
really? You only use the yeah. So this is the thing. Like patient can have PE, DVT. That is
mhm.
AE. I mean, patient might have might be post-surgery or whatever. There's a clear reason for PE.
Yeah.
It's not from the drug. We know that. But if it happened during clinical trial, you
Mhm.
are reporting it as AE.
Okay. I see.
It's an adverse events, but the causality will remain unknown, but we can always guess, right? So AE is whatever happened. So it's not about causality. Causality is what the investigator kind of reasons, and this is possibly this.
Hmm.
And
Okay.
you call it immune related. Yeah.
Yeah. Okay, that makes sense. I'll change that.
Yeah.
Because we have that data too.
Yeah. So same thing with Liam. Liam, all DART paper, all AE, all grade AE, grade 3-4 AE and immune related AE is the sort of like the basic way to describe. Yeah.
Do you want all of that to be described in the abstract level too, or just for the manuscript?
Manuscript abstract is you can, yeah, doesn't
Okay.
have to be too detailed. Yeah.
And then one more question. So I was writing up the like platelet count, neutrophil count, lymphocyte count, neutrophil to lymphocyte ratio information. Should I make a table for it? Or is it okay to just write down like the median for each?
Um, I think it's okay to write it as is.
Okay.
Yep.
Okay. Um, and then, so for the discussion, this is like the structure I was gonna use. Do you have any feedback on it?
I don't think we need, well, toxicity can be like 1 or 2 sentences because this is not, you can say the toxicity were not any different from any of the prior nivo-ipi combination trials that were reported. You can kind of incorporate that into any like clinical outcome paragraph. It doesn't deserve 1 paragraph. You know what I mean?
Okay.
Yeah. And if in ACC, if there's any also ongoing clinical trial, you can list them. Like they're ongoing, so you won't have any results, but
Mhm.
still you can kind of cite them.
Okay, yeah.
Also, if it's a trial that's been open for like, 6 months or more, they may have some sort of abstract, preliminary result abstract. So those are not searchable in PubMed. So go to like Google or the main ones like SITC, AACR, ASCO. Sometimes there's, if it's a salivary gland, there's like head and neck cancer, some sort of conference. So do some like abstract search, see if anything comes from oral presentation or something. It won't be in PubMed. So
Okay.
same thing for you, Liam. Okay. I think, yeah, I like this contents.
Okay.
So I guess what we know so far. So what is the overall impression that we get, like from what we have? I mean, it's small study
Mm-hmm.
and there's 0 PR,
There was one PR.
1 PR.
Yeah.
And how durable was it?
Um, 46 months.
Oh, that's pretty good.
Yeah.
And is that ongoing, or who, is there anybody ongoing here? No, all progressed?
Uh, I'm not sure.
So that line, ACC, that to me looks like ongoing.
Mm-hmm.
So we should know who has ongoing response or the stable disease or what, you know.
Mm-hmm.
Usually they put like in the duration like a plus for ongoing censored ones. So ask the statistician that like we need to know who, you know, if there's ongoing,
Okay.
like whether, you know, the, well, here actually there's number 8, right? Patient number 8 has PD is 0. So to me that's ongoing.
Oh, okay. I see.
Yeah. So yeah, so we found it. So there's one on, yeah. So so write that in the result. There's still ongoing, you know, after 32 months.
Mm-hmm.
That's pretty good.
Okay. Yeah.
So, so ACC chemo targeted, like, you know, nothing really works. But you shouldn't say nothing works. There's actually a one drug that has been filed to FDA. It's a BEGF2 inhibitor.
Mm-hmm.
So you should mention that in discussion or something, like, you know, is there like a drug specifically approved for ACC? The answer is no until now, but there's actually a breakthrough designation clinical trial that FDA is reviewing at this moment. Did you write that? Oh yeah, riboceranib. Yeah.
Yeah. This one.
Yeah. So this is not approved, but this is under review of the FDA. But anyway, you can say there's no standard of care, or like FDA approved medical therapy for this.
Mm-hmm. In the conclusion, right? Standard
Yeah.
therapy. Okay.
So and then the implication is that you know, learning from, oh yeah. So what, learning from these patients, what are the biomarkers?
I have a table of that too. Yeah.
You have what?
Oh, sorry, you were talking about the were you asking or were you like talking about what to
Oh
put in?
yeah, in the discussion, like, you know, understanding who are these people who will have response and durable, you know, response. And we need to understand what their biomarkers are. You know, our study is limited in, you know, looking at that, but you know, larger number of studies will be, you know, we'll be able to find out who they are or things like that. And the other thing that can spin out from this project is, I'm sure we'll have all like H&E slides from this. Yeah.
Mm-hmm.
So maybe, like, how many patients in total?
24.
24. So ACC is head and neck.
19 ACC.
19 ACC, and the others were non-ACC salivary.
Yeah.
Okay. So we don't know if any of them had high till. Most of them will have very low till. But what if? Hmm. So what I was thinking is maybe we should really pull the H&E slides of these. Like all the participants. And see we can do same, like scan it and check the till score for them as well. We can try and see if there's any correlation. And we can ask, Alex is our pathologist that I work with, so we'll see if he can pull up those slides for us. And Liam, can you check if this will be still covered by our protocol, or because this is ACC, do we need to write another protocol?
You mean the retrospective one?
Yeah. Does it just say lung cancer or other?
Yeah, it's just lung cancer. We were planning to make an amendment.
Why
broadening the scope.
don't you make an amendment to lung cancer and other solid tumors?
Mhm.
Just write and other solid tumors, and that should cover it, and maybe increase sample size a little bit, and and then say and add like till tumor infiltrating lymphocyte score or something. Yeah, so whatever we do here can be covered under that.
Mhm.
Yeah, let's make amendment for that, and then add Richard as like a study personnel for the IRB.
Yeah, so he's already in the study, and
Oh, okay.
we can go ahead with the amendments.
Yeah. So Richard, I mean, this one we'll send, but I think we could look at the TILs for these tumor types. So the next step would be MRN for all these samples, and if you go to their chart, you can find their sample number, like H&E slide. If you go to pathology section, you'll see the sample ID, or then we can request that to path department and then scan it and see if there's any rough correlation. And it could be flat, till 0 for every histology, and but we don't know until we see.
Okay, yeah. I think I might have that information already, but this is not for this paper, right? This is for like future, like.
Yeah,
Okay,
but it's gonna take too much.
okay.
I will send you the Lunit paper to you as well, so that you will look at what they did in different histology. I'll send to Liam as well so that you have it. Okay. All right. Anything else, Richard?
Oh yeah, so quickly for the figures, so table 1 is going to be like the patient summary. Table 2, I was thinking of having like the best response on there.
Yeah.
Table 3 was gonna be adverse events. So these are all immune related. I'll like separate out like
For
non,
the table, you don't have to separate out immune versus non-immune. It's okay to do just everything AE.
okay.
Yeah, that's fine.
Okay.
Can
And then-
you show me table 1 again? Does
Yeah,
it,
this is gonna be changed probably.
so show me the non-ACC histologies. I can't read it. Can you zoom? Yeah,
Yeah.
that's too long from a low grade. Huh. What is parotid gland adenocarcinoma? Huh. So that was 3 of them, or just adenocarcinoma, which is not common. Adenocarcinoma, parotid gland. So for the purpose of the table, why don't you put arising from low grade by, just use that in the text. But for the table purpose, you can take that out. It's too long.
Okay. The entire like myoepithelial carcinoma from low grade
And
biphasic.
arising from, just starting from arising from, take that out. Take that part out, arising from.
Mhm.
Low grade, that the whole paragraph, just use that in text. Manuscript text.
Okay, so only say that in the manuscript text. but
Yeah,
not-
yeah.
Okay.
And then parotid is a site of the tumor, but the first and third one, we didn't talk about that, so. And adenoid cystic, the site is also important. Where did it arise from?
Mm-hmm.
Is it minor salivary gland, major? Is it parotid gland? There's sublingual. So I think if you know from the information, breaking down by the site under its histology
Yeah.
is important. And I would do, let's say salivary duct carcinoma. If you know what gland, then put that in the parenthesis next to it, because it's just one patient. And all above it, all 3 patients are from parotid, and so adenocarcinoma, and put that in the parenthesis like parotid gland or something. So I want you to separate like histology and site of origin. If you don't know, then I guess we can't write it.
Mm. Okay.
Yeah, so describe that in the table as well as in the text, main text.
Okay. Okay. I think they're making a new table with like BMI too. Well, yeah, they kind of like lost touch back in like December, but we'll keep getting updates from them. And then moving on, so adverse events, blah, blah, blah. I'll delete this table because I guess we don't need it. Like it's already included in the other table.
Yeah.
Okay, let's take that out. And then this is a table I made with the NGS findings for each patient and
Yeah,
also like the best response. Should I include anything else in here?
so just 4 patient?
Yeah, there are only 4.
So the first patient, PD-L1 not available, was it not done because it wasn't ordered, or what do you think? Like, it's not to say sometimes it says tissue insufficient or something.
So what I did was I went into Epic and I went to like search on the patient profile and I typed in like PD, PDL, PDL1. I like different variations of that to try to look for PDL1, like immunohistochemical staining results. And if nothing showed up, then I wrote down not available.
Sometimes Tempest, so our path department can do PDL1, but sometimes Tempest report, there's a separate report for just PDL1. So I want to make sure you looked at it.
Okay. I think I've checked that already. One of them had like PDL1 like RNA expression, but I can look again and check if they have a report on that.
If you have RNA expression, you can put that in the parentheses, like RNA expression was, amplified or not, or something, because it was looked at.
Mhm.
And for TMB, what non-detectable at Garden, is that ND?
Yeah.
So TMB is not. It's could not be calculated, more like it's not detect or not detect. So could not be calculated. Also, for assay, Tempest and Garden should only be used in the method, like how we did NGS in blood and tissue. For blood, you can say circulating tumor DNA, NGS, and tissue, NGS.
Mhm.
Yeah, for Tempest, it's the tissue NGS and RNA-seq, both, because they're doing both.
Mhm.
Uh, so for assay, write those generic names, and only in the method you write like these were, tissue and blood, circulating tumor DNA, assay were performed, and in the parentheses you write Tempest and Gardens. And for the Tempest, you write Tempest and comma where their headquarters is, those usually that's how you write those company essays.
Okay. Yeah, I'll write down the whole name of the assay. I just like wrote that here for now, but yeah,
Yeah.
I'll describe it in the methods section.
And also for patient ID, for the purpose of publication, I think you should like you could use like 6, 7, 10, 14 if that's the, like for for simplicity, just patient 1 to 20 or whatever that is, you have it in there. Because it gets too specific.
Okay, I'll just change it to like 6, 7, 10, 14.
Yeah.
Okay.
Wow, so we, apart from these 4, we don't have any other information, right?
Not from the websites that I
Okay.
looked at.
Okay. So I think looking at TIL, because everyone should have H&E slides. So yeah, let's get that patient list, and you can send me and Liam, and Liam, once you got the list and confirm that they're complete, then come to me and we'll write letter to Alex together. CC Richard and see what happens after that. Yeah.
Okay. And then the RECIST, PFS, OS. We're getting the iRECIST data. And then these are the tables I calculated for NOR, neutrophil count, platelet count,
Hmm.
and then that's it.
Yeah, we looked at it before together, right?
Yep, yeah.
You go up to the main, yeah, this is sort of the main ACC, non-ACC. Mm, So ACC is little different because they usually grow slowly. So because there's no good control, I guess in the discussion you can write as a limitation. The natural history of ACC, a lot of them are slow progression or slow growth rate. So
Mhm.
without randomization or good control, it's hard to say whether certain treatment have benefited. Unless you have like, clear shrinkage of tumor like PR. But
Mhm.
just with PFS, it's always challenging to say whether a certain therapy benefited the patients or not when everyone received the same therapy. So that's just like a basic discussion limitation for our patient paper. But the fact that there is actually one PR is promising, actually it worked.
Yeah.
But we don't know why. I mean, we can only guess. And you could say, um, well, actually, can you show me the PR patient? The patient has tempus, right? Does show me the
Yeah.
tempus. Uh,
This patient.
yeah. So, like maybe this is good for discussion, like a BAP1 frame shift mutation, MCL1 copy number gain, MDM4 copy number gain, NRAS, PTGS. I don't know anything about BCOR, but read about this gene. See if they have any capability of making tumor inflamed or like immunogenic in this what's considered non-immunogenic tumor ACC. And write about it. Like maybe like we found these, like there's only one case, but there are literature supporting that these might be the driver of immune response.
Okay.
Yeah, so that's a good discussion to have. Now, the other thing is the RNA signature or HLA subtype, and which are all performed in Tempest reports. Can you pull up the report? Are you able to go to Tempest website and pull up that patient original report? So I think
For this patient or for all of them?
no PR.
I don't think this patient had an RNA-seq done. I only saw it for this patient here.
Oh, really?
Yeah.
My understanding is a default. Everyone gets it.
Huh.
So why don't, if you can't find it in patient chart,
Yeah.
it should still be in the Tempest like homepage.
Okay. I
Did
can
you actually go into the Tempest website or did you just look at the scanned PDF files?
I went on the Tempest website, like logged in, like searched up their name, and then like all of their like tests came up and I like
Okay.
read through them.
So,
Yeah.
are you able to go to the PR patient? Can you share your screen?
Yeah, I can go to Tempest.
Yeah. Let's do that right now. We're here.
Um And then page number 6, their name. Let me check that real quick.
You see how the RNA is listed there? I've not seen one that had no RNA. Oh, is it this patient?
Yeah.
Wow, so there's no RNA.
Mm-hmm. Same for the other two.
Wow. So there's nothing. This is it. Order. Let's look at other patients.
Yeah.
Go to the home, like the first page. And let's click on, like, let's say not the liquid HR. Yeah, just click on that patient. Go to summary, yeah. So yeah, here usually it has PDL1, RNA expression, RNA. And then there's usually a research button. Can you go down? Is there? Because the research will show you. Oh, it's at the end. Then nothing else.
Yep.
Below.
Yeah.
Oh. Hey, Liam, do you know where to find the HLA? Is it RNA expression? Or...
I do not.
Oh, click immunotherapy. See, so it says for research use only, right?
Mhm.
So this will have, DNA repair, HLA type, PDL1 expression by RNA,
Yeah.
and then all the other immune checkpoint expression levels.
Yeah.
And then we go down. There's immune infiltration. So this is the T cell infiltration. This is the same thing we've done with our previous papers using the TIL algorithm from TCGA. But that's all RNA based. And then you have neoantigen prediction right here. So I think what we can do is that so they should have. I don't know if they'll have anything left over. So let's do this. Let's do this. For all 4 patients, you have their, track number, whatever, like the patient ID, Tempus ID. And Liam, using your like Tempus, our contact personnel's, just email them to see me and Richard. Get that list from Richard, and email them and say, we know these are ordered a few years ago, but is it possible to get the RNA expression and immunotherapy assays, RNA assays, and PDL1 if they can do it, and whatever slide that they have, or leftover tissue, or if they have done the essay and not reported it, or I don't know, whatever they can, ask them if they can also release those reports.
Okay.
Yeah.
I'll send that over to Leo.
Yeah, that will be a quick turnover. They should be able to say, no, we can't do any of those, or, you know, let's see what we have, and they can get back to us.
Okay, so we're inquiring about the RNA sequencing and just the PDL1 status.
Yeah, RNA sequencing and, you know, this two section, RNA expression and immunotherapy section, the report for those, yeah.
Okay.
Okay,
Okay, good.
and then that was it for me.
Okay,
Um, yeah,
okay. Good. So, yeah, next week, let's see how, yeah, we can improve.
mhm.
We're almost there. I think you can just write discussion. If you have every, you know. Oh, yeah. So is BMS reviewing, or where are we with the abstract?
I sent it. They haven't gone back yet, but
They should give us full week or something, right?
yeah, they said they give it, I think, at the end of this week.
Oh, okay. So if you don't get it by Friday, just send them another email, like,
Mhm.
yeah, same thing with other three authors. Just tell them, you know, get back to us by the end of this week or something, yeah.
Yeah, okay.
All right.
Yeah.
Anything else?
No, that's it for me. Yeah,
Okay, great.
thanks for the feedback.
Thank you. Okay, let's go to Eugene. I know she's in Korea, so. Are you available, Eugene? Maybe she's not. Okay, we'll go to Jian then.
Actually, did my voice is clear, Jian? Jian, could you hear my voice? Could you? So actually, for Eugene told me that she only want to present the table. She revised it. It will be short. I think there's some emergency, but I think she will be back again.
Okay, we'll wait for her so that you both can.
Yeah.
Present together. Okay, Jian, can you give us update?
Yes, this is a brief communication. It is almost done, but we are still waiting the response from Professor Ankit and the Ashurt team. And target journal is the Journal of Heart and Lung Transplantation. And after completion, I counted the word count. It was 972 issued, less than 1,000 words. So it is good. And the reference count is 10. It is available up to 10. And this is the figure. Figure and table, only 3 can be submitted. So I will submit 1 figure and 2 tables. So I made A, B, C, D, E, F, G, H, very big figure. And this A, B, C, D is already showed you. And this is a new one, H. I made the cumulative risk of post-transplant malignancy. Whether it is lung cancer or not, we can't distinguish, but we can describe that.
Oh, this is but I guess these are all cancer, but we don't know if this is recurrent cancer or new cancer. Is that what you meant?
No, it's a new cancer, but it could be lung cancer or it could be the other type of the cancer.
Other, yeah. Cumulative incidence. I guess these are numbers of patients, right?
Yes.
But don't we need like a percentage too? Like out of how many?
Oh,
Because people don't know the denominator.
okay. Do you want to put the percentage into the figure or just describe in manuscript
Figure.
figure? Right. And
And that those are and then this you did like is that 20 x-axis. This month.
yes, it is a month. It is shown in here, so I didn't duplicate.
So I'm thinking because it's pretty long, like, can we change to years so that people can read it better? But I guess 20 hard to. One year, you could do 2-year, 4-year. The numbers will change, but still it just comes more naturally.
The other figures are
All month?
from, yes, all month. So do you want to change?
840. Yeah, I think year is much better for people to understand.
All right.
Yeah, let's make all other figures all like
Mhm.
year.
And about grant, Liam told me there is no specific grant that we need to describe. But I need to ask the Professor Ankit, there will be something. Because Professor Ankit said, I should write the COI, a funding source.
Yeah. So ask Ankit, like the source of Liam's salary, what fund it's coming from, and then we can write that. Yeah.
Okay.
So just regarding that, I checked with our administrators, and my funding doesn't come from any grants. Apparently, it's coming directly from Dr. Barat's PI account.
Oh, PI account, okay.
Mhm.
So it's
And
not
I
really-
think, yeah, Dr. Barat has other grants that he wanted to mention in the COI.
Oh, okay.
Mm.
Oh, in the COI.
Or so he did say in an email to like send it to him so he can fill out. I forget if it was like the grant or the COI information or both.
Oh,
As far
so
as I know, it was funding.
funding, okay. Yeah. So yeah. He should let us know if there's any funding he wants to give credit to. Yeah. Let's see. Okay. Word
Alright.
count reference. So it is really a brief communication, like up to 10 reference.
Yeah. Yeah. It was hard to make it less than 1,000 words. And next is review article. Now, almost the initial draft is done. But still, we need to figure out the funding source from Professor Anki. And when now I'm still revising the manuscript in better quality. So after finishing this manuscript, I will send it you and Professor Anki to get some advice, especially about the surgical section.
Mhm.
Mhm.
Okay.
And next is the ctDNA. Well, actually, there was a really big issue during the holidays. I sent the samples to Predicent,
Mhm.
and some of the professor in our Korean team. Yeah, he was so angry that I sent the sample without his permission. So there was a really big issue. Well, I can't handle it even. So, well, right now, Dr. Isu Che, even he's angry to me. So I don't know how to, but already samples sent to Predicent.
They
I
got-
asked him, yeah. I don't know whether he didn't want to proceed this study or he just angry because I didn't get his permission. I don't know. Maybe he thought those samples belong to him, but it's not, obviously.
But he knew about the project.
Yes, he suggested, because actually at first I said him that I want to make a project that I can do by myself.
Mhm.
But he said there will be not much subject that you can do by yourself. So this could be really fancy and you can do everything. I will support you totally.
Mhm.
And then now it happened. So I don't know his thought right now. I was so disappointed during the holiday. It was horrible. Yeah, actually. But
Oh.
well, no, yeah, I prayed and prayed. Is this really God? Do you want me to do? What do you want me? But now I just let them go. I will see
So where
why.
no so well, let's think about the project first. So Predicent got the ctDNA, well, they got
Mhm.
the blood, and
Yes.
did they run it, or do you know where they are?
Oh, they're running the blood sample test right now. And tissue NGS test is holding now because of I asked them to make a HNA slide. But even that study, maybe I can't proceed it, unfortunately. Because well, as far as I know, Nora hit my back. Yeah. She,
So Nora doesn't want to do it?
yeah, I don't know, maybe she was jealous or I don't know why she doesn't want to proceed this. She doesn't support it anymore. But well, Dr. Che, I was so hard. I don't know. Well,
So
I
we-
feel like abandoned by my team.
Oh,
Oh my gosh. Oh my God. Yeah.
oh, okay, we'll talk more about that later.
Yeah. Yeah.
But so right now we cannot do the tissue, no H&E, no, I mean, well, did they,
Already tissue are sent.
tissue is sent, but they can, it's a frozen tissue, you said?
Yes, frozen tissue. They can
They can do NGS, but not,
yes, they can do NGS with the frozen tissue,
but
but
they cannot do TIL.
yeah,
Okay,
and even Nora doesn't want to work with the learning. I don't know why. There will be some issue, but well, there's nothing that I can do at this point. I'm so sorry, Dr. Che.
okay, that's okay. So tissue NGS and ctDNA blood will still proceed. That
Mhm,
right?
mhm.
Okay. And then, but the second cohort for the proteomics, It's not
No,
going to work.
yeah,
Do you know, is there a reason why? Or is they think
I
it's
don't,
precious sample that you shouldn't reuse? Is that,
I don't know. Really, I don't know. Maybe Dr. Che was angry that I didn't get the permission,
hmm,
or really he didn't want to pursue this subject.
hmm,
And there are the other team members, they were not glad that I'm pursuing this subject.
hmm, hmm, hmm.
Mhm.
Okay, so Liam, how about, I think like it was more Delphi and is it
Mhm.
Biodesics or they're reviewing it? So we should just let them know that we have some regulatory hurdles regarding the samples, so we'll put this project on hold until we resolve this first. So let them know that we're kind of, yeah,
Yeah, I'm so sorry.
yeah, it's okay. And let Lunit know about the like there's, just say regulatory hurdle and say, you know, we're just gonna put this on hold until we resolve this first and get back to you guys. So that just, you know, update them real time.
Okay.
Okay. So I guess
Uh,
it's just the ctDNA, but we'll have the tissue NGS, which is a good thing.
yeah,
Already
yeah.
said.
Yeah, I was so idiot. I knew that the collaboration with the other professor is really hard. I knew that several years ago, but I did again. Wow, yeah. That's why I just write an article by myself without discuss other professor. Yeah.
It's
Well,
amazing.
yeah,
Yeah.
absolutely. You know, Koreans,
Uh,
I think some members are jealous.
mm,
They want some big project like this,
uh,
but they didn't get any chance. And then they can do is just to make it stop.
uh,
Most of the issues I couldn't figure out the reason, but later in 2 or 3 years, I finally realized that there was no reason.
there's
Not
no.
even surprised. Yeah,
Mhm.
not even surprised. Yeah, I thought, wow, again.
Hmm.
Okay.
So
Okay, Dr. Che.
collaboration is this hard. Collaboration is very hard. A lot of times,
I'm
yeah.
I'm really upset that I feel like abandoned. Do you know what I mean? Yeah.
Uh, yeah,
Mhm.
I can't imagine, like, yeah, but let's yeah, work with what we have, and let's be like, you know, every week let's check what they have done, and let's do some serious correlation work when we get the data out.
Okay.
Yeah. Going back to the frozen sample, and
Uh-huh.
so I heard what Luna said. So is it next to impossible? Like the people won't believe frozen sample making a tiny slide at that level? I'm just thinking, what is the best way to assess till with the frozen that we have? Because it's so, yeah.
Yeah. I will find several references, read, and then review. I will let you know.
Yeah, maybe maybe not even using Lunit, but if you can still use Frozen to make one section, and maybe the structure of the tissue may be distorted or something, but you can still kind of count the total till number or something by doing a simple, I don't know, CD3, IHC, and just, maybe. Yeah, because like if you can't get a slide, then is there any other way? Maybe to just, because now Prenison has a sample, let's do some digging on that topic. Let me know. Yeah. Okay. Is this your journal club?
Yes. Can I
Yes.
make a presentation right now?
Yeah. Real quick. Yeah.
Yeah, this article is published very recently, and this is about the oncology necessity for complete removal of residual microcalcification after neoadjuvant chemotherapy in breast cancer. The most common symptom of breast cancer is definitely palpable lump, but the microcalcification is the second common symptoms. And the definition of microcalcification is the deposit of a calcium product, which is less than 1 millimeter. And because it containing calcium, it look like just a bone, very white spots in mammography. And if this calcium product is larger than 1 millimeter but less than 5 millimeter, we call it just calcification. And if it is larger than 5 millimeter, we call it macrocalcification. And as most of the experts, the well-trained physicians can distinguish whether it is a malignant microcalcification or is just benign. But most of the benign calcification shows a calcification or macrocalcification, which is combined with fibroadenoma or other benign disease or aging process. But microcalcification is mostly clustered. I will show you. Yeah, clustered or linear shape. So we can distinguish this microcalcification. Most of the malignant microcalcification are shown in ductal carcinoma in situ, which is a very early breast cancer, and even advanced breast cancer, especially in HER2 and triple-negative breast cancer. But after neoadjuvant chemotherapy, sometimes 20 to 30% of cases, microcalcification still remained without change. So that is the problem. Can we reduce the surgical scale or not? We're thinking about that. As you know, the role of neoadjuvant chemotherapy is the inoperable breast cancer become operable and larger tumor become smaller. And if there is a higher tumor burden, that it make it a lower burden. But after neoadjuvant chemotherapy, the changing patterns are so various, especially in hormone-positive breast cancer. It does not shrink as a concentric. It shows a diffuse and scattered pattern, which means we can't reduce surgical scale, even if the cancer reduced. And so there could be three groups: no residual microcalcification, or no change of microcalcification, or even increased microcalcification. So these below two groups could be the important to this in determining the surgical scales. So aims of this study was to establish the clinical implication by a retrospective study investigating the changes in breast cancer and microcalcification after neoadjuvant chemotherapy, and as a prospective study by evaluating whole breast specimen to prove the necessity of a mastectomy, with evaluating viable cancer cells around the residual microcalcification. So this trial we call the RASMIN study. The main mass was reduced, just like PCR, but still microcalcification didn't change. That we call it the RASMIN group, or otherwise they were all included in non-RASMIN group. So this was the retrospective cohort. There was 370 breast cancer, but finally 49 cases were included in RASMIN group and other 95 was included in non-RASMIN group. And as a prospective study, after mastectomy, we sliced 1 centimeter interval, and then we performed the specimen mammography, and we evaluated at each specimen whether the viable cancer cells remained. So this is a real specimen. We cut every whole specimen as a 1 centimeter interval. And we evaluated each part, whether the cancer cells remained. You can see these very dark red spots are calcification, microcalcification, calcium products. And here you can see a blue box. There still remain the cancer cells, but there are different places. And even we couldn't predict where the invasive focus are remained. And we performed the statistical analysis to compare two groups. Well, interestingly, RASMIN group showed a higher PCR rate and lower scale of axillary surgery, and higher incidence of HER2 positive breast cancer, and even triple negative breast cancer.
Wait,
And-
go back.
Yeah.
So RASMIN group had higher PCR?
Yes, higher PCR.
So RASMIN is no change.
No change, but main cancer, most of case, they were reduced.
Oh, most of the cancer. The calcification remained, but the tumor
Yes,
smaller or the,
yes, yes.
and the axillary surgery is not important? Is that? because they're gone?
No, it shows a similar trend as a breast.
So it had less dissection? Is that?
Yes, less dissection.
Oh,
Only sentinel lymph node biopsy was done.
and less, more HER2,
More HER2.
but slightly more. not
Yeah,
much.
very slightly, but they show the statistical significance,
Oh,
and also triple negative breast.
okay. Okay.
And PCR rate was higher, and even the partial response is almost 47%, which means even if you thought about the PCR, it could be a PCR, but still almost 47% has remained invasive focus of cancer. So this was the retrospective study. When you look at this table, microcalcification does not change much, but in ultrasound in RASMIN group, it reduced much. 5.2 from 5.2 to 1.9, and in breast MRI, 5.8 to 1.3. So here's the question: because the PCR was higher in RASMIN group, then can we perform breast conserving surgery rather than mastectomy for this patient? So we performed a prospective study with 5 consecutive breast cancer cases. This is one of the case, 63 years old female patient. She had a 7 centimeter extent of mass with a suspicious microcalcification. It was proven as invasive lobular cancer with a prominent high-grade DCIS. Stage was a 3A and hormone positive and HER2 positive. She received the neoadjuvant Perjeta, Herceptin, docetaxel, and carboplatin. This is the initial image. You can see the microcalcification here, and tumor was large. You can see in breast MRI, the tumor involved in most of part of her left breast. And after 2 months, still microcalcification is remained without change, but cancer reduced. Even in breast MRI, the enhancement has gone. We can't find main mass right now. And after 2 more months, still microcalcifications remained, but we have only 1 centimeter of cancer spot. So we thought it could be a PCR or very small focus of invasive cancer. When we compare these 3 time points, you can see the microcalcification did not change at all. But in ultrasound, the cancer reduced very much. But we could not be sure that there was no invasive focus. So we decided to perform simple mastectomy with a sentinel lymph node biopsy. So this was the specimen. And we cut 1 centimeter interval slices. And then we performed the specimen mammography. You can see the microcalcification was shown in 7 pieces, which means it could be almost 7 centimeter. And in the report, there was no residual carcinoma, which means PCR, even no DCIS.
Can you go back? So what was the purpose of this specimen 2627?
Yeah.
So this is to show. Well, I guess you can't see calcification from this slide, right? You can? Can
We
you?
can't. We can't.
Okay, just the
Only, yes, microcalcification is shown in X-ray. We
Only
can't distinguish with our bare eyes.
So this is how tumors got smaller each time. Is that
No, these are just cut slices.
from same
Yes, the whole breast specimen.
like different
Yes.
what's the stained?
Stained are the marking to evaluate the margin by pathologists.
Oh, that's what staining is.
Yeah, and that blue mark is for sentinel lymph node biopsy. Mostly we use indigo carmine to tracking the sentinel lymph node.
Oh, so but this is breast, but you inject indigo carmine so that you follow the lymphatic?
Yes,
Oh.
that's why these are blue.
Oh, okay.
And very dark stained on the surface are the done by pathologists to evaluate the margin.
Evaluate the margin, okay. Okay. And this one is tumor, the red.
No, these are not tumors, just we can distinguish microcalcification.
Oh, these are microcalcification by
Yes.
X, but is it X-ray?
Yes, the mammography.
Oh, this is mammography, but it looks,
Yes.
oh,
Specimen mammography. Well, mammography is a kind of X-ray,
yeah,
so we can
Wow.
distinguish them.
I've not seen it before.
Oh,
It looks like a picture to me, almost like, but then it's
uh,
X-ray. Ah,
yeah. Here you can see the microclassification.
classification.
Yes.
Wow. Okay.
So, as I mentioned, this case showed the PCR, even no metastatic lymph node. But other 4 cases, they were not pure PCR. Even 2 cases had invasive focus, and other 2 cases had cases that had a DCIS, which means we can't skip, we can't omit the surgery. And the problem is then we can't predict where the remained focus are placed. So this is why we still need to complete removal of microclassification, even if the main mass was reduced. So for oncologic safety, residual microclassification after neoadjuvant chemotherapy should be completely removed. And the whole specimen should be assessed because sometimes pathologists miss very small focus of invasive cancer. It could be only 1 millimeter or 2 millimeter. So it is not easy, but still we need to assess very thoroughly.
Hmm. So can you go back 1 slide?
Mhm.
So these are 5 cases with Resmin, no change.
No change. Yeah, Resmin as a prospective study.
Was it only 5 or this is representative case? Was it-
Only 5, because there were 49 cases in a retrospective study, but these were prospective study,
Oh, this
which
is a
means
perspective.
we, sliced and evaluate each sample.
So this is prospective study. You found 5 Resmin and found 3 PCR.
Yes, but pure PCR was detected only 1 case.
Because the other 2 had
DCIS,
DCIS.
yes. DCIS still should be removed because it will proceed, it will progress to the invasive cancer.
Hmm.
So which means 80% of cases required the surgery still.
So in other breast cancer studies, if there's a DCIS still remaining, do you report that PCR?
Yes,
Okay.
without invasive focus, we call it PCR, but it is not real PCR, which means it still need the surgery.
I see.
Yeah.
So then the next question is, what is the biological explanation for calcification, like this phenomena? Why would having, because my initial thought was, well, calcification is like a dead, it's a remnant. It's not biologically active. So it shouldn't change whether you respond or not. That's just my bias. What is what is happening biologically here?
Well, there were several biologic cycles, and there was so many theories, but if the microclassification is related to the cancer cell, that calcium products are produced by cancer cell.
Hmm,
So if they don't produce any more,
hmm.
then if the cancer cells are um, dead after neoadjuvant chemotherapy, then the calcium also disappear.
So what, how, calcium deposits can disappear? Is there like a homeosis, like you know, it can dissolve? Uh, I'm just thinking about there's calcification in aorta and
Mhm.
blood vessels. Versus like a cancer calcification. You know, how does calcification go away?
Um,
Should be different than, because what's calcified is already there. Cancer disappears.
oh, calcification changes.
Yeah,
Sometimes it disappear.
do you know what mechanism it disappears?
Give me one second.
It's like homeosis, homeostasis, stasis. So the other non-resonant group had calcification disappear, or did some calcification got bigger?
Yes. The non-resonant group had the change of a microcalcification, whether it could be reduced or increased.
But wouldn't those two groups be different? Bigger or smaller change?
Pardon?
Calcification that got larger versus smaller,
Uh-huh.
two groups might be different in terms of outcome.
Outcome, what? Which outcome?
You know, like a tumor PCR,
Uh,
because you categorize the no change,
mhm.
but
Yeah.
wouldn't a group that with calcification got really smaller or disappeared versus the calcification that got larger, do they differ in PCR rate?
Um, yeah.
Hmm.
Yeah.
Suppose mechanism of in vitro memory cell mineralization. There is beta glycophosphate. Memory cell, and then enhanced proliferation. So osteopontin HA crystal. So HA is the hydroxy apatite that has calcium inside, right? So it's saying the mechanism is, this mechanism is proposing that HA enhances proliferation and migration.
And the components of classification between malignant and benign, they were different.
Components are different. Okay.
Mhm.
And they look different. Okay. Interesting. So if they, so how do you explain biologically if they did not change? If so, is it the fact that they didn't get larger, they are same size, means
Mm-hmm.
tumor is not producing. So if the tumor gets larger and larger, then the calcification gets larger and larger, right?
Sometimes, but sometimes not.
Hmm.
They react independently
Hmm.
sometimes. Mostly they go, they shows a similar trend, but sometimes.
So I would look at it the other side, like the PCR group and non-PCR group,
Mm-hmm.
and then in those two groups, separate how how the calcification changed.
Mm-hmm.
Then you'll be able to say is, no change or getting smaller is the predictor of PCR. I understand no change is better than some change, better PCR there, but I think biologically it's more convincing to do that way, PCR, no PCR. And then see, like, the calcification size, does it go up or down in both groups, and kind of compare it that way.
Oh, yeah, okay.
But this is already published? Your
Yes,
paper?
yeah, it's published.
Yeah.
It
So, I
was
mean,
focused on the surgical scale, whether
um,
it could be reduced or not. But the answer was we can't reduce.
yeah. What about other groups have looked at the same question?
Yeah, yes. Most of surgeons reported that they can't reduce surgical scale. Still needs a mastectomy if there is diffuse microcalcification.
So is resume something you made up or someone else used that?
I made it. It is just the name of a trial. Yeah, our study.
Oh, okay.
It was a so long title, so. I
Okay,
just
so
chose
if
it.
there's no change in calcification, the other groups found that there's a higher PCR rate too?
Uh,
Or did you show it for the first
no,
time?
no, it was not consistent.
Not consistent. Okay.
Yes, various.
Okay. I mean,
The
you have
result-
close to 100 patients, so yeah, I would definitely, yeah, make that figure. PCR, non-PCR,
Mhm.
and then the microcalcification, just like the spider plot, like,
Uh-huh.
what's the trend of the change,
Mhm.
and go from there.
Yeah.
And maybe
Okay.
use that delta of micro
Mhm.
change, as a, predictor of the neoadjuvant therapy response or something like that.
Yeah, that
Yeah.
could be interesting.
Very,
I will make a second article with this
yeah,
quote.
yeah, because you have all the data, so.
Yeah.
But so the biologist, this theory says the more calcification you have, the tumor is likely to proliferate and migrate more, is what it says.
I don't think so. I don't think so. Because when cancer died, cancer cells, sometimes dead cancer cells make a calcification sometimes. That
Oh,
doesn't mean that it's a progress. So we can't predict, we can't distinguish.
hmm. I see. It's very complicated.
Yes.
Then why did you do the study? You thought,
Because I wanted to reduce the surgical skills at the first.
um,
I tried to reduce because at that case, as I showed, I really wanted to perform breast conserving surgery because it was only 1 centimeter in ultrasound,
hmm,
but I couldn't be sure that the other breast part really doesn't have an invasive focus. I couldn't be sure. So I still decided to perform mastectomy.
hmm,
But patients were so disappointed because she received the whole neoadjuvant chemotherapy and she thought the cancer reduced. It was only 1 centimeter. But still, I recommended mastectomy. So that's why I tried to figure out really mastectomy is still required or
Mm.
not.
okay. Yeah, I like it because it all starts with how can I do what's best for the patient?
Yes.
Yeah, that's always our driving
Mhm.
motivation and yeah, yeah. Good. Well, thank you for sharing your work. I think we can
Yes,
learn from all these. Yeah,
that's all I have.
thank you.
Eugene,
I know Eugene's back. Let's take 10-minute break and we'll resume in 10 minutes.
Thank you, Dr.
All right, let's resume.
Okay, so today I just want to present the updated figures and tables for hyperprogression project. And I'll share my screen. Can you see my screen?
Yep.
So, yeah. So table 1, clinical and pathological characteristics of patients. And I put some. So I have a question, Dr. Tu. You mentioned you recommend me to write a little bit about the regimens of immunotherapy. So I try to do that as a footnote format. And I found out that we actually didn't gather specific, regimen of other treatments combined with immunotherapy when we collected the data. So I just wrote like this. With immunotherapy, chemotherapy was combined in 22 patients, targeted therapy was combined in 2 patients, and clinical trial drugs with chemotherapy were given in 2 patients. Do you want to specify the each types of chemo or targeted or clinical trial drug? I think to do that, I need to look them up again. Or are we good as of now?
This is okay. So I would do other treatments and just put the other treatment, comma, and you just put chemo n equals 22. Targeted therapy n equals 2. So just rather than making it into sentence, just make it
Okay.
into more
Okay.
just a concise way.
Yeah, we'll do that. And okay. Yeah. Other than that, like no need for any more footnotes. I think it's pretty obvious, in a
Yeah.
way.
Mhm.
Yeah. And table 2 is the incidence. Sorry. So the numbers changed a bit, but not that hugely. So that those were updated here, and I try to label each different definition like you recommended last time: HPDC, HPDS, HPDF. And here we denote the exact definition. And just for the regimen, I wrote like this: each regimen was counted separately if patients received multiple regimens containing immunotherapy. Would this be okay?
No, that makes it more confusing.
Oh, I mean,
So
so
each
number of
regimen, it's not
each
each regimen.
regimen. Okay. Like, so
Um,
yeah, the total number of patients are 122, but then number of treatments, or I could try to look up some reference, but I think not many papers did like this. So
yeah, we might get criticized for doing this, but this is, I would consider this, so I think in the method and in the footnote, both, you should say,
Mhm.
136 minus 121. 15 patients,
Yes, they received.
more, 15 patients received more than one. So no one got 3 immunotherapy regimen, right? So it's only 2.
Yes, at the maximum 2.
So just be clear, 15 patients got 2 immunotherapy regimens. Therefore, what's a better word?
We consider or we
I just don't like the word regimen, because the regimen
Oh.
is more like recipe.
mm,
You know, you
mm,
don't, so it's,
each just how
Each-
about just each treatment
each
that they remember,
treatment
okay?
case. Number of treatment case. How about number of treatment cases? Number of treatment cases.
Yes.
So 15 patients, uh,
Ah,
were, that had 2 treatment, were 15 patient were
treated.
analyzed as having 2 distinct treatment cases. Yeah, I like that better.
Mm,
15 patients were analyzed
as having two
as
different.
having 2 distinct treatment cases.
And no need to explain for that, like because they were treated with two different immunotherapy containing.
Since
regimens.
they were treated with 2 different immunotherapy regimens.
Okay, yeah, I think it would work.
Yeah,
I will write this in method as well.
yeah.
Okay, thank you. And for the and you mentioned that I need to write out or explain about HPTC or SF, these kind of acronyms in the footnote as well. So but here it's pretty clear. So I just wrote like this: HPTC and CSF were defined according to its different definition of hyperprogression, such as by 3 different study groups. And I do remember you want me to put the reference here. I will do that when we put all the reference all together.
Yeah, according to each different definition. I don't like the each there. You know, you can give it. Okay,
And I will move on. Yeah.
and also, you know, like a HPD, TGK,
Oh
all
yeah,
that, you have to write the acronyms here in the footnote.
I see. I missed that. Sorry. Yeah.
It has to be an
Mhm.
independent source of information.
Okay. Yeah, abbreviation, something like that.
Yeah, same thing with HPDC, what is C and all that, yeah.
Oh, okay.
You have to write all the abbreviations here.
Then for HPDC, like it should be write down like or should I just mention the C here means champion? Hmm.
According to the definition suggested by Champion et al., and then you put reference there.
Okay, in that way I could.
I know it's long, but it's a footnote, so you
Right.
write what that is.
Right. And then okay. Yeah, got it. And then table 3 is about PFS and OS for 3 different definitions, and I chose 3 weeks as a landmark because it produces the best result, I think. And I formatted the table like this. I hope this would make sense.
So what is M?
M here. Oh, I have a question. I'm sorry. So I explained M in the figure 1 because so I just order table first and then figure later. But then in figure one, so this is our figure one, and here I define HPDM like this, and still I do need to explain about HPDM in the tables, different tables, right? Or I was a little bit confused about, do I really have to write it out for each different acronym in each and every footnote of figure and tables, or is it okay if I do that in the first figure or first table?
I don't understand your question. Can you repeat?
Okay, so here in the figure one, we have HPDC, S, and M, but we have these in table 1 and 2, right? Table 2, maybe table 3. So should I explain about them every time we have them, or is it just okay for me to do that once in table 2 or in figure 1? Like, I wrote like this, HPDC. I actually try to explain about HPDC as that.
Oh, you don't have to explain what Champiad did. Because it's an acronym, just explain hyperprogression as defined by the Champiad et al. That's it. And then if you're using the modified Champiad, maybe I like M, small letter M, HPDC to differentiate it from the original one. Do you understand? Is Eugene not on anymore?
I think he's good. He's good. Where is he?
Eugene, can you hear me?
Maybe she got a call.
Yeah. Okay, let's she may come back. So Arnie, can you share what your updates?
Mm. Okay, for me, there's not a lot. Just I need to. For me, it's already for the discussion part. It's already like already like 60%. I need to add on from something from our previous discussion about the Wang paper, and also need to proofread it. I think I will ask Liam to proofread it maybe tomorrow or like 2 days after before show it to you. Also actually I want to discuss the things with when there is Eugene. So for the Champion, Dr. Che, do you remember when we put the target when we add on the modified one? We add on the target lesion for the total tumor size, right? For the modified one. But we cannot categorize as a progressive disease if progressive, stable, or like what is partial response. Because I think because Eugene and me have this kind of discussion last week. Eugene asked me like, Arnie, why this patient like before it's not progressive, but when we add on the target lesion, it become progressive. And I realized when we add on the target lesions, we cannot categorize them as a progressive or stable, right? Because there's no criteria. Right now, the criteria for RESIS, if it's progressive, whether there is a new lesions or it's more than 30%. If we add on the target lesion to the total tumor size, we don't have the criteria anymore to make it progressive disease, stable, or like a partial response. Do you have any opinions about that, Dr. Che?
I don't understand your question well. Can you turn on the camera?
I'm using the computer. I will use my iPad then. I'm using the main computer in the lab. Yeah.
Anyway, can you rephrase your question?
So
So Arnie, are you asking basically how to calculate the percentage change of the tumor if we
Yeah,
start
yeah,
including
yeah,
the new lesions?
yes, but there's no criteria to count that, Liam. I mean, when you make progressive disease, stable disease, and partial response, you have the RESIS criteria, right? But once you add on the target lesion to the total tumor size, you don't have that criteria anymore. So how come you put this as progressive disease, but they don't have such criteria? Except
Well, didn't we just add the dimensions?
yeah, we just, but I think Eugene asked me before, like, can we make it as progressive disease or stable? Because we don't have, except we make our own criteria, like more than 20% or more than 30%. It's just like we making our own criteria to make it as progressive disease. So I think
We-
you can repress it.
Yeah, I think that's the whole point of the modification though, right? So we're just saying that we're going to add the new dimensions of the new lesions too, and then just use that. And then
Eugene,
use the same cutoff percentages from RESIS 101.
Eugene says back. Eugene, do you
Yes, yes, I think I can help you.
no,
So
yeah, do you hear my question is? Do you hear?
yes, yes, I heard it. Yeah,
This is the one that you asked me last week, right?
right, right.
Yeah, but yeah, that's why I want to discuss it in here because I feel like we don't have the criteria to describe it as PD, stable disease, or like partial response because we modify it. So we need to have like our own like criteria if you want to make it progressive. Yeah, you can
Right.
replace it again to Dr. Che maybe.
Yeah, I know this is very tricky question, and it actually came up from the feedback that Dr. Shea gave us last week, lab meeting. So I'll just share my screen just to explain about this question. So I mm, so while looking up our tables last weekend, Dr. Shea made a point that why numbers are so different between the original definition and modified one in terms of classifying patients into PD, PR, SD. And I realized I made a huge mistake calculating them. So let me just, I think this one. And while tracking down that error, I found we have some problem. So basically, I'm sorry, my laptop is a little bit slow, but the main point is we collected the data as yeah, I'll just go directly into the problem. So actually, these are the data we collected from the first time. And if you look at here, this is just this original scan information, like, and Arnie and a few Zuni and people collected some of the lesions here according to the RECIST 101. And then they also, you know, decided
The
whether,
response,
they
yeah,
decided
response
response
criteria.
here. They decided response here, they recorded here. But the mistake that I made actually was, I'll just share another screen. When I actually calculate the incidence from the R, I actually did it in a wrong way. So if you hear, I actually didn't look at the response at the first when I tried it first. So I just redefined or I just try to decide response PD, PR, SD just based on the tumor, the size of the lesion. But then, so like I made a code like this over 20%, let's call that PD, and decreased over 30%, let's call that as PR, and rest of them SD. But then so actually this was the cause of that difference of numbers between the original definition and modified one. But then I realized I need to refer to the response that were decided by the readers, rather than just trying to classify them based on just the sum of the lesion, because if there's a new lesion in any way, that should be considered as a PD. So I missed that, and I actually kind of revised this code. But then my next question was, so for the original one, I referred to their reading, PD or PRSD, read by the original people who see and then decide the scans, decide based on scans, right? But then after the modified one, we only had numbers. We only had numbers. So here,
Exactly.
yeah, here like
Yeah.
we had kind of we had numbers here like this, but then we didn't have any reading about that.
We doesn't have the response criteria, Dr. Che. So
Yes.
we only have the total. We only have like the tumor size, but we doesn't have the response criteria. So I think in here that this is like the thing that we want to discuss, like how far we want to make it. We want to make our personal response criteria, or we just just show it in the graphic that this is like the difference if we put if we conclude the target lesion for the tumor size. I think that's kind of the questions.
So the new definition is a hyperprogression definition. We're not proposing to change anything about RECIST. RECIST will not change.
Right.
So you should define your response by RECIST criteria, not by modified hyperprogression definition. Do you understand?
But if it's by RECIST, Dr. Che, if the new target, if the new target, we summarize the new target lesion to the total target lesions, then it means is there we still concluded as a progressive disease because actually they have new lesions? Because for me,
just the presence of new lesion is progressive disease by RECIST.
Yeah.
Right.
So we're not making any changes there.
Right. We didn't make any change, but
So RECIST is RECIST. I'm not touching RECIST. I'm modifying the hyperprogression definition.
right. But then in hyperprogression definition, sometimes there are two components, right? TGR, TGK, which
Yeah.
should be calculated by these kind of newly calculated sum of the target lesion.
Mhm.
We can reflect these numbers directly into that calculation.
Yeah.
But then for the for Champia, Champia and Ferrar, they need the classification of the RECIST itself, right? The
Uh-huh.
response. But then, so for example, my question is, so we according to our suggestion, we kind of have this kind of separate columns for the sum of the lesions, right? The diameters are changed because we included we kind of reflect the new lesions as quantitative way.
Mm-hmm.
Then how about the response itself? Should it be changing? I mean, we kind of have confusion. Like, for example, this patient, his tumor size at post immunotherapy evaluation increased to 81,
Mm-hmm.
but then his response was, regardless of the change of the lesion, was initially PD.
Uh-huh. Does that
And
change?
yeah, does that change, or is there a way we can?
No, I'm asking, would that PD change if we use our modify criteria?
That's the reasons, Dr. Che, we asked, because we don't have the criteria if we change the summarize, how to describe it,
I
like
don't think, yeah. I think I got what the Dr. Che. So for this case, it doesn't change. I think it's just his tumor size just increased, and he's PD in any way. Because
Yeah, so I don't think it's going to change or matter for the PD patients. The issue might be in a
for
subset of
SD
patients who are
yes,
SD or like
right,
partial response,
correct, yeah,
where if we add the new lesions,
right, that's correct.
they
So
might
here,
change to progressive. Well, they might be hyper progressive, but
Mhm.
per RECIST 101 be categorized as stable disease or even PR.
right,
I
correct.
think I get it, because because after you sum the target lesions to the new one, it can be more than 30%, right? That's why it can be changed for the response criteria.
Yeah,
If
so
you
But if you have
basically,
any new target, they will be PD by definition. Do you understand?
yes, yeah,
but
but
then
this is no, the point is not if it's like if it's like if there is new target lesions and it's PD, then it means like if already progressive disease, even we modify it, it's still PD, right? Then if it's like stable disease or like a partial response, then it's like more than 30% criteria to change it into progressive disease. I think because the criteria is two. If you want to be PD, it's more than 30% progression or like there is new lesion.
The 30% does not mean anything, because if you have new lesion, then it's progressive disease. So adding any new target should not change PD. Do you understand?
yeah, that makes
Add-
sense.
So there shouldn't be change in resist response output. If there is one, then you did something wrong. Does that make sense to you?
Yeah, makes
Yeah.
sense to me. But then why? So honestly, like I wasn't paying that much attention to. So
If you add new
yeah,
lesion, and if they still remain SD, there's something wrong. Presence of new measurable lesion is PD itself.
yeah. So you mean that for our modification, only patients who were originally classified as PD should be having different numbers, right? Because we only sum up the numbers that were already reflected as a PD in
Right.
any way. But then my question is why some patients, for example, this patient, recorded to have another target lesion. I think so.
Can you which one? Can you show me which one?
For example, here,
Uh-huh.
He's definitely PR, partial response, because his religion decreased a lot. But then for like these columns are made. Arnie, you remember, right? We
Oh
kind of,
yeah. So if already if PR, you must have like how many percent decrease? Even there is new target lesion, but if the tumor size is decreasing, like more than 35 or 30 or like 20, I forget, but it will become
Okay.
partial response.
So you mean
Because
that
for PR,
uh-huh.
so if it's for PR, that the
Confused.
if the total is like decreasing, it will be go to PR. Even
Even
they have
there's a new
like
lesion.
a new lesion. Yeah,
Huh.
for PR. I think
Huh.
we can reopen again the RECIST criteria, I think, because it's been like a long time we didn't count it, but I quite sure. Because if you like you see like this one from 65 to 36, I don't
Right.
think this is like not partial response. Which MRI is that? I will open it. Wait, I will open the table. You can go first. I will check the table.
Maybe
Oh, let me tell you, whether one lesion disappeared or had PR, it does not matter. If you have new lesion that's measurable, and you have to say this is cancer. Sometimes you have GGO that is inflammation. So a lot of times if I see new lesion or something growing, I say equivocal. I don't know what this is. I don't know if this is inflammation or not. So I don't end up calling it progression. But if you call that cancer, it's a measurable cancer. If that's new, does not matter if it's PR or CR in the initial lesion. It is progression. To me, it's very clear. Do you understand?
yeah, I think yeah. So
I want you to make sure there's no error here.
yeah, I think for the patients who are already classified as PD, it's okay to keep this number. But I think for PR or SD,
Give me a second. Give me a second.
So if you say there's a new measurable lesion,
mhm.
there should be 0 case that says PR or SD. If you have it here, that's an error. You gotta figure out what mistake you've made.
Right. I'm pretty sure like not
Dr. Che, response criteria category in RECIST system for partial response is more than 30% decrease of the target lesions. They didn't put the new one if it's for the non-target lesion for the partial response.
but Arnie, could you just check that?
Yeah, I check it. I do it right now actually. Wait a second.
Okay.
I do it right now because I just open it.
So Arnie, that is the definition of PR. But definition of PD trumps everything else. Do you understand that?
Yeah, I understand.
So that's why we see a lot of mixed response. Some target lesions get smaller, some target lesions get larger, and some there are new lesions. Is there any more questions? I think it's very crystal clear to me. I don't know what other questions you have.
So yeah, I think the fact that we have some numbers even for new numbers of target lesion, even for PR or SD patients, I think that gave us a little bit, that gave us all like mistake
Eugene.
confusion. Uh-huh.
It's PD. It's PD. I don't know what happened. It's PD.
Okay, so Arnie, so could you just check one more time with these?
Yeah, I would check for the PR one, because if there is, yeah, but I think it's right. If there is like new target lesion, you should be PD. I think the mistake that I can check it again. Every patient that have new target lesions that we count the response. I can check it today for that one. So it means for the modified one, for the PD, that won't change anything. But for the stable disease, or is there anything that you find change for the stable one?
Yeah, look at that one. 61, 64.
Yes, here as well.
So here's the thing. To be eligible for target, so 61 to 64, is that the change you made?
I think
Is that
so.
the change? So does that mean there's a new 3mm lesion? Or
I
is it
think-
centimeter? Is it
No,
centimeter?
no. It should be compared like this. So here, tumor size 2 means the tumor size calculated on baseline.
Okay,
And here, baseline new sum of lesion, I just label like this. So it means like 40 people calculate the sum of lesion originally like as a 48 centimeter, but after adding new lesions, I think it doesn't make sense. The number increased up to 61. But then to be like this, it should be recorded as a PD in any way, because this means that it has new lesions.
so I'm worried about the quality of this data. I assume both of you looked at it, Eugene and Arnie. Did anybody else look at this data?
It's already been looked at like multiple times actually. If there is something, actually I'm quite sure with my own one, because Eugene, which table that you show actually? Which part?
New
Which
of
one?
HPD.
Because there's too many. Is that the last one?
No, Arnie, I think I know what you're trying to say. You want to compare the raw and the copied
Yeah,
one, but yeah, but I'm
I
pretty
already
sure.
it will be kind of be the same, because like this Excel is already being like restructured couple times. Even like after we find it, we restructure it again like multiple times, and working with the PD and counting the response. We almost did it like 2 or 3 times, I think, before.
Why do we have still so many errors? So let me tell you this. We're interested in new lesions on a therapy of response, on a therapy of interest. So baseline, pre-baseline, baseline, and then on treatment. So there's 3 different points.
Right.
I am not interested in new lesion at baseline. Pre-baseline to baseline, we're not interested in new lesions, okay? People are not responding to therapy,
Right.
okay? We're not interested in hyperprogression at that level. We are not.
Mm.
We're interested in the new therapy, whether that is causing hyperprogression or not. So pre-baseline to baseline, figuring out what's new or not does not mean much, okay?
Okay.
Baseline is the most important. Baseline is the start. Baseline is what's going to give us, it's a starting point, because there is no new lesion for baseline. Whatever is there, you count, okay? Baseline, not pre-baseline. Baseline, you count whatever there is. Pre-baseline, same thing, just count whatever there is. We don't care what is new, what is not new. Okay, just treat it as a baseline. Pre-baseline will be a baseline for the whole definition. Baseline is baseline. We don't care about what's new or not. It's only the on-treatment scan that we will count what is new. We will not count 3 millimeter, 4 millimeter ones because they're not measurable. We're only counting the measurable new lesions on treatment scan. That is going to affect only the hyperprogression definition. That is not going to affect RECIST definition. I think it's crystal clear. I don't understand the errors that we see, or the sum of the, I don't understand this column, sum of the tumor 2 plus new target.
So it's just it's actually for at the first we thought if there is we need also sum up from the baseline if there is new target, but I feel like sum up the baseline if there is new target from the pre-baseline. I don't, it's like showing progressions before the treatment. That's one. And actually, Dr. Che, I'm agree with you that we didn't change anything about the RECIST, but I feel after I'm doing this, I'm just feel like actually RECIST have a lot of lacks if it's come to hyperprogressions. That's why I feel like that's the reason why, especially after Wang also published that paper, actually it just make it more clear that RECIST actually is not perfect for hyperprogressions. That's what actually I want to say, because the problem, they only have most like 10, the maximum only 10 lesions, like 5 organ, each organ 2 lesions, so maximum 10. You cannot like count like the real size with RECIST, but that's important in hyperprogressions. That's like the kind of the idea actually I want to kind of discuss it also, whether I should talk about that or not in the paper. But if it's like this, then it means like we don't touch anything with the RECIST stuff then.
So RECIST will remain RECIST. We're not going to touch RECIST. We're not going to say we're going to do modified RECIST. So I think that's clear. We're going to touch hyperprogression definition. We're going to say if we define target lesions as only the existing target lesions as defined by RECIST, we don't think it's fair when we assess hyperprogression. So we will take out the limitation of the number of target lesions per organs. Any new target lesions that pop up, we will use that to calculate TGR or TGK. Okay, not RECIST. Doesn't have anything to do with RECIST. It's just a new definition of hyperprogression. Do you understand?
I understand. And then if that it means I want to propose something, then this is will be like give me a little bit of job, but I want to propose things like this. Eugene, the total of the incidence of the progressive, this is only like 14, right? The PD, the hyperprogression one, hyperprogressive, 14, right? The incidence.
The incidence of our data,
Mhm.
less than 14. It's actually
Then-
HPDS around 12, 12.4, 10.
Okay, then I want to propose something to Dr. Che. If then give me one day for today, I want to check again the CT scan of the hyperprogression patients. Then we include all the new lesions, because the new lesions that we include is only maximum 2 for the criteria. But if we put more like all the lesions that we can find in the CT scan, maybe the number of the graphic of the Excel will be different. Not the graphics, the sum of the graphic. Like, what do you thought about that? Because before we have limitations about the total of the new target lesions also. But if we right now we check again for the CT scan, then we sum all the lesion that we can find, maybe the statistic of the graphic will be show different. It will be show increase more. What do you think about it? It's only 12. I think I can do that for today.
I thought that's what you did. So my answer is yes, you should do that way. So again, we are not operating under resist. We're operating under new definition. Now, let me ask you both, Eugene and Arnie. What did Wang do? Does Dr. Wang's group have 2 per organ limitation when they use their new definition? Or did they
No.
count all the new lesions?
No, they count all the new lesions and they make it like patients with 1 new lesions, how many hyperprogression disease, 2 lesion, how many hyperprogressive disease, more than 2 lesion, how many hyperprogressive disease. I think the approach by Wang is like to the approach by Wang is like to make it to show the limitation by RECIST, you know, like I feel like they want to put aside the limitation, so there's no limitation of the number of the target, so I want to count as much as we can in that paper.
What Dr. Wang's group did is exactly what I told you guys to do. They didn't do anything. Their thoughts and their analysis is
Mhm.
exactly reflecting what I told you guys to do. It is not something that's novel. And I did not tell you a limitation of 2 per organ when I said add all new target lesions. Okay,
Okay.
so I think there was miscommunication. I think we should definitely look at all new target lesions. Again, I think there was confusion on your end that we're not changing resist. Resist is resist. For hyperprogression definition, we're adding all new target lesion. What Wang's paper is helping us is they looked at number of new lesions and see, does that make any change? Well, they found out only 1 new lesion does not change much. And we can ask the same question for our cohort.
I think because I will recheck the CT scan again. I will make the table for like 1 new lesion or like 2 or more than 2 new lesions. I can like, how many categorize 1, 2, 3 or more than 3 lesions that you want to put in the table. So I can like make it since the start while I check the CT scan.
So this is how we do the analysis. Where you look at the distribution 1, 2, 3, 4, 5, 6, 7, 8. You look at the distribution. You look at the ideal cutoff point by looking at the data. The more cutoff you have, the better. 1 or 2 or more, 1, 2, 3 or more, 1, 2, 3 or 4 or more. You do it all different ways and see what graph looks the best to you.
Okay, I will do it
My
today then.
answer to all similar questions. Like, how do you want it? Well, we have to look at the data to find out what's the best way to do it. So it's called sensitivity analysis. You would apply different cutoffs and make all the graphs and choose the best one for your publication.
Okay, I will do that today for all the hyperprogression incidence patients. I think the NRM still the same, right, Eugene? The
Yes.
one that, yeah, okay.
So again, I am very disappointed about the quality of the data. I am, disappointed that you guys did not understand what the RECIST criteria was, and then still left the PR. So that's a major mistake. If we didn't catch this and we published this data, this is a very basic mistake. It should not have happened. So I want you to be aware that clinical research is a serious deal. That we can't make things up. And I know this is, new definition, and you guys are probably confused about, are we changing RECIST? Maybe I wasn't so much clear about that. But the errors that we found today are serious ones, and I want you to really learn from these mistakes.
Dr. Che, actually, I'm sorry. Actually, I just checked the raw data about the PR response one. the new lesions actually is pneumonitis in the CT scan. That's why I think the one who count the RECIST before, they didn't put it as new target lesions because it's like a new right upper lobe opacity, suggested pneumonitis or like superimposed infections. That's why I think they didn't count it as new target lesions in that for that MRN number. But I will try to recheck it again for the one that we have like PR. I will try to recheck it again after this.
I
So-
know,
So new target lesion, like I said, this is why all these has to be done by medical doctors and people who treat cancer. Because, you know, a radiologist will even call something a new lesion. And then I see it, oh, I think that's not metastasis. I think that's something else. Then you call that radiologist, say, I think this is not the target lesion. And then they will change the RECIST for you. Okay, that's my job. So that's sort of beyond your expertise sometimes. So that's why you guys have me as a mentor, not rely on your own clinical wisdom. But if you have a case, there's a question, you always have to run it by me. If you don't run it by me, I will assume that every case is very straightforward.
Dr. Che, it means if in the CT scan said that related radiation pneumonitis or superimposed infections, we didn't put it as new target, right? We didn't count it as new target, right? Because it's an infection.
That's what I just told you. You have to be convinced that new lesion is coming from the original cancer. If you're not convinced, that's not a target lesion.
Okay, thank you, Dr. Che. I'm sorry. Thank you.
And if you don't know, Dr. Jian can answer all that questions for you too.
Yes.
yeah. Thank you. Thank you, and I also apologize for not checking this already, not noticing this earlier. But I agree with Arnie in some point that sometimes, like, when we actually evaluated this CT scan data, like Suni and Arnie, they were the only one at the lab, and because of the time limitation, I don't think they, you know, run all the like kind of confusing cases by you. But yeah, I think we will definitely have to recheck for at least for the post baseline CT scans.
But
and
for the partial response one, actually it's correct, Eugene. It's partial response because actually it's like super infections, but because we put it like new opacity, that's why they put it as the new targetation. But I will check it again once more after this, especially
Understood,
for the
understood, yeah.
PD and CT scan. I think
Okay.
so.
Let's talk to you later regarding this
Yeah.
issue.
Okay. Eugene, can you go back to the ones you were presenting?
Of course, but yeah, not sure whether it's the right time to do that because many things will be changing according to
Right.
but then still the format.
Yeah, go back, go to that figure. I was saying for the modified, it's better to write MHPDC, MHPDF, just to avoid confusion. Okay.
Okay.
Yeah,
Although we actually we're not going to use a MHPDS and MHPDF. We're gonna denote them here, at least here like that, right?
at least here, because
At least here, yeah, that's what I thought. Yeah, it's a
You
little
did.
bit. Okay. Here I will define like these, and but then for the rest of the figure, maybe for like this, I just did HPDC, S, and M.
so I think you have to be consistent. So here also MHPDC.
Okay,
I want you to do.
Okay, yeah. And then I, as Jian and Arnie recommended, I try to put HR and p-value in the curve as well. And it just as of now, results are pretty interesting that both, at least at the 3-week landmark analysis, both HPD and PD without HPD, they were both associated with worse prognosis quite significantly.
So again, why is this called landmark analysis?
We just we only considered patients who were followed up until 3 weeks after initiation of treatment. So patients are excluded if they are not if something happened before 3 weeks. That's the essence of landmark analysis. It's done in the Champia paper as well. They put the 8 weeks landmark.
So these are patients who were receiving treatment at least 3 weeks. Is that what it means?
No, who are followed up at least 3 weeks after initiation of treatment,
Follow up
at least for 3 weeks.
at least for 3 weeks.
So not many patients are excluded actually at this time point, but then when you go further, when we apply 6 weeks and 9 weeks, quite a lot of numbers are excluded.
Where's
So
6 weeks?
so 6 weeks and 9 weeks, I just put them as a supplementary figure here. So 6 and 9 weeks landmark analysis. So actually, the landmark is denoted in the very below of the graph. So ABC is the PFS for 6 weeks landmark. I didn't made it like this as of now. I'll do that later. But here, if you look at here, it's interesting. So for HPDC and S, HPD and non. Yeah, so the
if you do 6 and 9, which is 6 and which is 9?
These are all 6, and 9s are at below. I mean, we have 3 for each landmark time point, so I just arrange them in this way. So all above are 6 weeks, and all below is 9 weeks. 6 weeks, 9 weeks.
So
And for HPDC, there's no patient who are followed up who are not censored after 9 weeks. So there's no HPDC here in this graph.
this questions the value of doing this type of analysis. If, let's say, hyperprogression patients will be determined, let's say I do 6-week scan usually, and
Yes.
it shows hyperprogression per the definition. I'm not following their patients anymore. So there will be no 9-week follow-up for that patient. So what is the even value of doing this analysis when our topic is hyperprogression?
I mean, actually, this landmark analysis are kind of, it's a way of dealing with the time-dependent variable. So hyperprogression, HPD is not fixed variable, as you know, like it can happen at any time after starting treatment, mostly within some time, but so that's actually, so after receiving some feedback from another professor, pointing out that you should approach this as differently from just original Kaplan-Meier curve analysis because this is time-dependent variable. I looked up some ways to deal with that, and one of the way was doing landmark analysis, and that was done by Champia and other like writers of similar paper a few times, so that's why I applied this. And the reason why sometimes we do multiple time landmark is that this is done as a sensitive analysis as well. So, but then maybe in our cases, HPD incidence is not that high. For HPDC, it's just less than 5%. So I think that may be the reason why we don't have any patients at 9 weeks landmark, which I mean, sometimes we can have HPD patient even at 9 weeks landmark, if that patient developed HPD at 9 weeks, but no one actually did that. For Champia, the time frame when HPD occurred was 5 or 6 weeks. That's why we only have one patient at 6 weeks. On the rest of the patients were censored before 6 weeks because they developed HPD at that earlier. So, but then for Sarabuzid, patients quite develop HPD even after like 9 weeks. That's why they are still red line, a few patients left. And I'm not sure, like,
So let me ask you this question. Did we do resist
mhm.
for second on treatment CT scans?
Second, no, we only did first post-treatment CT scan.
Right.
Yes.
This is a pure matter of when we did the CT scan. It's just a physician, every physician will order CT scan at different time. 4 week,
Right,
5
right.
week, 7 week. So this has nothing to do with tumor biology. This means then when was the first scan ordered? Because we're not, to talk about biology, we have to compare the first and second on treatment CT scan, correct?
Right. So I actually calculate the median time interval from treatment of initiation of treatment and then first
Scan.
post scan, and it was around 6 weeks actually.
Yeah. So to me, this landmark analysis doesn't really mean much. If we are doing a clinical trial measuring resist for all on treatment number 1, number 2, number 3, number 4 scans, yes, it means something to find out when the hyperprogression happened. But to me, if you're only measuring one very first post-treatment on treatment scan, the
Okay.
week doesn't mean much.
Okay.
Do you get it?
Then
No biological information there.
Yeah, but then when I received that, the professor really strongly recommend me to I got the feeling that I really need to deal with this kind of issue of hyperprogression is time dependent variable. So, but I mean, yeah, then we can just do. So do you suggest me to just do one time point of landmark, or not even doing any landmark, just do it the original like Kaplan-Meier curve survival analysis? I mean, Dr. Wang, they didn't do landmark analysis too.
Okay, for your learning,
Mm-hmm.
in the ideal world, we should have resist for every CT scan on treatment.
Right,
Okay.
right. Yes.
And we should have progression defined by resist all the time, be consistent. Not by clinical progression by the investigator, like we did. Okay.
Yes.
Our paper, PFS, is a clinical progression.
Right.
Okay. So we're in a way using two different definition. And that's not good for any research. So in that ideal setting, it makes sense to do landmark analysis. But we're very limited. Okay. I can't tell you guys to do resist for all the scans.
Right.
Too much of your time. So I'm just compromising the quality of the paper. Now, when we when we're not operating in the ideal world, the value of landmark analysis goes down.
Mm. Understood.
So in the ideal world, then you would say landmark analysis is really important. In our setting, I think we can,
Just go with the original.
I think we can let go, but I think you made the figures already, so I think you can still use it as a supplemental figure. Yeah, I think you can use it as a supplemental figure. Just leave it, and then the reviewer might say it doesn't make any sense, don't do it, or but it's okay. You made it. I think we can utilize it. It's fine.
Yeah, my last question.
What I learned from go to the six week landmark.
Yes.
So look at the hyperprogression 6 weeks here. Modify. If you modify them, they actually did really well. So the hyperprogressors did as well as non-progressors.
Right.
So
So-
that's why our modified version, as opposed to Dr. Wang's paper, is not predictive at all because of these patients who are doing so well. Like these patients who develop new lesion are doing even better, sometimes better than the non-progressors. But I suggest that you look at, you look to see if this is true.
Okay.
If
Yeah.
the other patients were in, I don't know, like, I think you have to really look at the data again
Okay.
first to see if this graph is really true. Again, I know you ruled out pseudo hyperprogression. I think that's really important. Rule out pseudo hyperprogression.
Right.
And then if they're like, having new lesions here and there, and it's greater than the rate of growth is more than 2 times, and they're still doing better than non-PD, there's a problem. I think maybe they're doing better, but the chance that they'll do better is very slim. So I feel like there's some data quality issue here.
That's true. I mean, these 6 patients did
Yeah, are
really
doing really
better.
well. They're the best performance, like having new lesions pop up. So I would suggest look at all these 6 patients and see if there's any error.
Yeah, I think it's probably will be changed because I feel like the miscommunication is right, because like the first things we add on the new target lesions, but we just concluded best RECIST criteria, like the total of the new target lesions. But right now it's like limitless, right? We, as much as we can, as long as there is new target lesion, we'll add it. So I feel like it will be kind of changed basically, because before we have the limitations, like the maximum of the new target lesions also, but in this time we didn't have that limitations. So we will see how it's changed. And it should be changed, especially the graphic of the figure 2. I think it will be changed.
Also, make sure it's a measurable lesion. Follow the rules. So the
Yes, Dr. Chen.
measurable rule will be per the RECIST.
Oh, for the solid 10 millimeter, for the lymph node 15.
You never know if that's a non-specific something, right? So
Yes.
okay. Anything
Okay.
else?
So just to confirm that, just to make sure that for the main figure, you don't want me to restrict any, you don't want me to apply any landmark, right? Not even for a 3-week, right?
Right, for the main figure.
For the
Correct.
main figure, just original.
Everything goes to supplemental.
Okay, okay. Mm, okay, yeah.
So you don't have to call it landmark. You can, you could just, you can use the PFS curve, everything you generated. But you don't do landmark analysis. You just
Okay.
do the Kaplan-Meier analysis.
Okay. Yeah, and then just with a different criteria, maybe. Yeah, I'll just reach out to you
What
later.
do you mean there's a
and
criteria? Just the regular PFS and OS.
Regular PFS and OS and PFS and OS with some modification. I'm not sure about how I'm gonna talk about the change that I made for supplementary figure. If you're not gonna call it as a landmark, there should like.
No, I'm
um,
saying in the supplemental,
Okay,
take all the landmark analysis that you made.
to the
it.
supplementary. Okay,
But for the main figure, don't use it. For the main,
I
just
will.
do a regular PFS OS.
Okay.
Is that clear?
Yes, and in method section, I can describe it, or even I cannot describe in method.
method, you have to talk about what you did in supplemental figure. So yes, you have to say.
Okay. Yep, I think. Yeah, everything is clear.
No, actually, no.
No, okay.
Method. So supplemental data and you have supplemental method. So write that in the supplemental method
Okay.
for figures. And then, so you don't have to write that in the actual method. But in
Understood.
the main text, you can always refer to the supplemental figure 1, 2, it's okay. But you don't have to write the method in the main paper.
Okay.
Yeah, let's do that.
Okay. Understood. Yeah.
Is that it?
I think that's it for today for me.
So Eugene,
Mm-hmm.
did you attend Zoom meeting with Dr. Shin Hyun-jun?
When did it happen? Like last week, or? I received the email from him and I saw it, but then I didn't attend any Zoom meeting with him.
We didn't have a Zoom meeting yet, so we've been
Oh.
exchanging email communications, and we're working on the edits on our end, and then we are planning to request the Zoom meeting once we're ready to show him further analyses.
Okay, good, good. Let's, if it hasn't happened, let's see if he can make any time, anytime Tuesday morning. Just for like, 15 minutes or so. Anytime between 8 to 12. And we'll just, yeah. So the EJC is not an automatic submission. We can revise anything we need and then submit. So
Yeah, so we actually had a question about that too. So the EJC has a word limit that's shorter than that of Lancet. Lancet was 3,500 and EJC is 2,500.
oh, okay.
So we had a meeting, me, Eugene, and Shuhee had a meeting to discuss this. And obviously we would like to get your thoughts on this. Either
I
we can
know-
just cut out like major parts of it, or we can potentially explore splitting it.
No, I'm actually thinking taking 1,000 like words out is a big, a lot of work.
It is.
It's a lot of work. So I would go far as to find another journal then. Because it's not like we submitted anything.
Yeah.
We're gonna revise anyhow. So what did we have like the next list of journals that we had in mind? You know?
Not sure.
I don't
don't think
think
we-
so,
yeah, I
because
don't think
Juhi
we-
sent out like cold emails to these journals, and we started with Lancet because they were the ones who initially showed most interest.
Yeah. To maybe ask Juhi where she sent email to, and I'm sure we
Mhm.
discussed all this, but I just can't remember.
And also, Dr. Che, is like splitting this manuscript something you would consider, or should we try to keep it as one manuscript?
Oh, what do you mean? How splitting?
Um, again, up for discussion, but an idea was maybe we can split the narrative review from the meta-analysis.
But personally, I don't feel that would work very well, because meta-analysis usually needs some narrative review part as it is. So I'm agreeing with some taking some part of meta-analysis part. Maybe we can reduce it very much. Maybe to just sensitivity and specificity and just a few different subgroups. But yeah, personally, I don't feel that would work very much. But if Dr. J has another opinion, I mean, I can go with that as well.
So I think it's hard to separate. I think going with what we have is better. I think we should find another journal. So Liam, Eugene, like the 4 authors, look for write home for this journal. Lancet Public Health is something that I found that might be good. So this doesn't have to be oncology journal. This is, general population. Oncologists don't even see these patients. These are general population. So it's public health, not really epidemiology. This is a perspective. There's some like perspective studies too. So Lancet Public Health, or it's like a general medicine paper, Annal of Internal Medicine. I mean, look for like public arena in public health and medicine. And then like high impact journals in that field. And come up with some of the lists and impact factors, and we can decide where to submit it. But in the meantime, it's just a reformatting thing. And maybe prioritize journals that will have the same word limit, like 3,500. And then we can kind of pick and choose from those. Let's do that. There's PLOS Medicine, PLOS Medicine, PLOS maybe Public Health. There's JAMA Public Health. There's, I don't know. JNCI. Yeah. I mean, you can Google high impact cancer, public health, medicine journals, and then look for the ones that have the similar scope. and look at the word limits and make a list. And yeah, why don't you, Liam, why don't you be the leader to find the right home for this paper, and we'll do that on our next lab meeting, or you're here all the time, so you can kind of run it by me and I'll give you, yeah, let's not do the EJC. I think just making it shorter is a big, it's such a big difficult task at this level.
Understood.
But still work with Dr. Shin to make all the changes that he's advising.
Right, right. And Liam, like, does 3,000 sounds okay with modification?
Oh, even 3,000 is a little tough
Hmm, okay.
because like
I just,
we're really cramped already with 3,500.
I see.
Like we'll have to take out a whole chunk, like a whole like paragraph or like a
I know.
section to do that.
Okay, okay. Because I just found BMJ journal, they have Journal of Epidemiology and Community Health, and they allow us to write up to 3,000 words. So yeah, I'll just try to look up another one.
Okay.
So and then if you have like if Dr. Shin's comment is something that you guys don't understand or maybe difficult to do, run it by me as well. Okay.
Mm,
Mhm.
okay.
Okay. Let's take a 5-minute break, and then Arnie, do you have anything else to present, or
So I think that's okay because I think it's better to finish to check on it first. Then
okay? So yeah, we'll talk about Liam's projects after 5-minute break.
Sure.
Okay, I'm back. Just trying to take care of some clinical issues here. But yeah, Liam, you can present.
Okay, so a couple of things. First of all, the DREAM trial registry on the clinicaltrials.gov, I submitted the updates. I received an email saying that you have to approve those, approve that submission one more time. So
Let's
if
do
we
it
can-
together, because I
Okay.
forgot. Yeah.
uh,
Let's do it after this call. Yeah. Yeah. you come to
oh,
my-
okay. Yeah. And then I have the updated ovarian DART abstracts. So I'll show that to you now. So so I showed them to you before. And I just need to show you the updated clear cell cohort because we combined the 3 clear cell cohorts into one abstract.
Yeah.
And then the issue is word limit. It's over the word count by a bit. So if you can take a look and see how you might want to cut it down, I think that would be helpful.
Okay.
I'm going to send you the link here.
Mhm.
And then also a couple of things. So it seems like you have a lunch meeting today.
Yeah, I postponed it to 12:30.
Oh, okay. And then Dr. Sierra King is going to come to visit you around 1 p.m. Is that okay?
1 p.m.
Mm-hmm.
Yeah, tell her. Yeah, 1 p.m. is okay.
All right.
Can you, somehow I can't access it. Can you share it, just your screen?
Let me try something.
No, it's making me log in. I can't remember my password.
Oh, try this new link.
Oh yeah, it's working.
So here I changed the title to clear cell gynecologic cancer cohorts. Does that work for you?
Yeah, it's okay.
Okay. And
Wait.
then
Could be consistent with making it, capital or all small letters or whatever you want to do.
sure. So you've seen this one before, but the major changes are in the results section. And also in the background, again, I just changed it to clear cell gynecologic cancer cohorts. And then in parentheses, put in the cohort numbers.
So something like this can go because of, there's, if you need more space.
Mhm.
Enable. Yeah, like weeks can be WK, IV, you can, And then sometimes if you need more space, you can let this go, like CRPR. People know this already. But that's only when you really need space.
Yeah, I do. So, well, yeah, I
So
think
wait, this is complete response CR, not
Mhm.
confirmed.
Oh, so it's because for the Dart, we only use confirmed CR and confirmed PR to calculate ORR.
So you have to write confirmed complete. Oh, okay. Because you didn't write response here.
Yeah. Do you want me to write response there?
Oh, you. Yeah.
Okay.
Yeah, it's CC if you look at here, like. But anyway, if you need more space, you can write confirmed CR and PR. And people will still understand,
Okay.
but only if you need more space.
So the results section, we said that we are going to report the ORR separately for each cohort, but then combine them for the adverse effects or adverse events.
Yeah.
And because it's just a lot of numbers, I thought it would be best to present them in separate paragraphs, each cohort.
Huh?
But in doing so, like, we're way over the word count. And then the cervical and endometrial cohorts, they have an ORR of 0%. So it's only the ovarian cancer cohort that actually has like relevant information to present.
So I would, again, largest cohort to the smallest, 46, 45, 42. In that
Okay.
order, everything in that order.
Mhm.
And then ovarian has response so that positive results first, then negative.
Okay.
Unconfirmed PR. Unconfirmed PR. So you can let go of these numbers.
And just keep the median.
Yeah, just keep wait, you have a lot of numbers. If you're looking for space, you could do you can like 6 month. Wait. So 1 year PFS and 6 month PFS same?
Yeah,
what-
it's a small cohort, and that one patient has a very long PFS.
Okay. So 6 month PFS can stay. And then yeah, same thing here. I think you can do just median and for space you could let go of 6 month, 1 year for all of it.
Okay, for all 3 cohorts?
Yeah.
And for both PFS and OS?
Yes,
Okay,
that will
And
give you
just-
a lot of space and yeah,
and just keep the median then, right?
Yeah. yeah. All right, let me answer this call.
Sure.
Hey, Liam, I think I need some more time to resolve this clinical issue. So let's pause here. After lunch, we'll get back to it.
Okay, sounds good.
Okay.
Thank you.
Welcome.
We'll stop the lab meeting here for today. Thank you, everybody.
Thank you.